Recording. Well, welcome everyone. Nice to see so many names here participating. My name is Dr. Sarah Labroto. I am the PGY2 Pain and Palliative Care Residency Program Director here at the San Francisco VA. I am so excited to introduce my PGY2 Pain and Palliative Care Pharmacy resident, Dr. Nisha Lakshmi Iyer. She did some of her APPEs here at the San Francisco VA, and she was our Jerry-focused PGY1 resident last year, and we were happy to have her stick around for an extra year for some pain and palliative care training. So today, Dr. Iyer will be talking about managing the complex intersection of chronic pain and opioid use disorder, something we encounter quite often, at least in our practice. Go ahead and take it away.
Thank you, Sarah, for that introduction. So excited to be presenting to you all today. I've learned so much from all of your presentations, and I'm excited to contribute what I can. So as Sarah said, I will be presenting on managing the complex intersection of chronic pain and opioid use disorder today. I have nothing to disclose except for the fact that I will be asking for some audience participation. So just preparing you for that, I have a few patient case questions and a few activities for you all. By the end of today's presentation, you'll be able to identify and discuss 3 factors that add complexity to management of concomitant chronic pain and opioid use disorder. You'll be able to discuss the benefits and risks of the 3 agents that are considered medications for opioid use disorder. And you'll be able to recommend non-pharmacologic and pharmacologic interventions for a patient with concomitant pain and opioid use disorder. So I thought I'd start us off with some definitions today. So on the left side of the slide, starting with some chronic pain, it's pain that exists for greater than or equal to 3 months. And it can be caused by an underlying medical disease or condition, actual or potential tissue damage or injury, can be caused by medical treatment, can be caused by inflammation, or sometimes pain just has an unknown cause. And then on the right side of the slide here, I have opioid use disorder, or OUD, defined as a problematic pattern of opioid use leading to clinically significant impairment or distress. And that is taken verbatim from the DSM-5 criteria. For those who are familiar, it then kind of goes into quite a long list of different criteria that can be met. And then based on how many criteria are met, the patient can be diagnosed with either mild, moderate, or severe opioid use disorder. A few that stood out to me that I thought I would mention are opioids taken in larger amounts than intended, craving or strong desire to use opioids, recurrent opioid use resulting in failure to fulfill major role obligations at work, school, or home, or a great deal of time is spent in activities necessary to obtain the opioid, use the opioid, or recover from its effects. And all stats to show is that this isn't necessarily use of illicit opioids. This can actually come from prescribed opioids as well. So a little bit of epidemiology. Chronic pain per the CDC is the leading cause of disability in the United States. 1 in 5 US adults have chronic pain. These are the 2019 stats. And 1 in 14 adults experience high impact chronic pain, which is essentially defined as having pain most days or every day in the past 3 months that limited life or work activities. 2.0 million people in the United States have opioid use disorder per the 2018 statistics, and 10.3 million people reported misuse of opioids. Of those 10.3 million, 9.9 reported that those were actually prescription opioids. So next, I thought I'd spend a little bit of time talking about the complexities of the intersection between chronic pain and OUD. And I've kind of delineated it into 3 sections. So I thought we'd start off by talking about enhanced distress. And as promised, here's our first activity. So I'd like you all on the next slide to spot the similarities and differences between the diagram on the left and the diagram on the right. And here it is. And I think let's start with differences actually, and feel free to unmute yourself and speak or type in the chat box, whatever you feel comfortable with.
I don't understand.
Sorry, Siri was listening to my entire presentation there. So anyone spot any differences? Chronic pain versus OUD in the middle. Exactly. That's the difference. What's the same?
Everything else.
Everything else, yep. So essentially what I'm trying to show in this diagram is that chronic pain and opioid use disorder can result in some of the similar kind of subsequent side effects. So insomnia, lead to substance use or misuse, functional disabilities, stress, mental health disturbances, challenges in relationships, either at work or personal. And so what happens is if we have a patient who has both chronic pain and opioid use disorder, they can actually feed into each other, and it turns into this complex situation where they can cause a synergistic effect of exacerbating other comorbid conditions. And so I've summarized that as both conditions may result in similar complications, but then feed off each other. So the next complexity I wanted to address was synergistic pathophysiology. And so we know that the reward pathway plays a key role in both addiction and pain. And so what happens is opioids bind mu receptors in the ventral tegmental area, or the VTA of the brain. And that releases dopamine into the nucleus accumbens, or NAC, and that produces feelings of pleasure that reward the person's drug-taking behavior. So for example, if someone has chronic pain and they take an opioid medication for the first time, and then that binds the mu receptor, releases the dopamine, and then you kind of have this kind of pleasure pathway, and then the person then starts to associate, oh, if I take this opioid medication, then I'm gonna have pain relief and it's gonna give me some pleasure. And so there are kind of two models that psychologists and other clinicians have theorized when it comes to the reward pathway and how opioid use disorder can actually impact it. And one is the change set point model. And what that hypothesizes is that repeated opioid use leads to a lower baseline dopamine release without the presence of opioids. So essentially in the VTA, if there's no opioid at all at baseline, there's a little bit of dopamine that's being released to the NAC and, you know, stimulating the reward pathway. And over time, if someone's using opioids chronically, what happens is that the dopamine is not released until the opioid is in the system. And so at baseline, there's not as much dopamine being released. The other model I wanted to go over was the cognitive deficit model. And what this states is that, you know, after the reward pathway kind of leads into the prefrontal cortex, which are known as the brakes of the brain, right? So that's the part of the brain that's kind of evaluating risks and benefits and saying, hey, I know the opioids made me feel good, but now I've learned that there are a lot of side effects. Maybe this isn't the best thing for me, and kind of puts the brakes on the behavior. And what some clinicians hypothesize in addiction medicine or in opioid use disorder, that the prefrontal cortex may experience damage, and then it doesn't carry those signals and properly act as the brakes. For opioid use disorder specifically, clinicians lean more towards the change set point model. The cognitive deficit model is more in other substances such as stimulants. And so what this means is that people who have opioid use disorder may have lowered pain tolerance, increased sensitivity to pain, and higher incidence of chronic pain conditions. And that's kind of what exacerbates this intersection of the two disease states. Then lastly, I wanted to talk a little bit about some psychosocial barriers that exist. So patients who have opioid use disorder can face stigma. About 21.2 million people may have benefited from substance use disorder treatment in 2018, but only 3.7 million people received it. Okay. And then there's always this potential for patient-provider mistrust in any situation for any disease state, but seems to be exacerbated in situations where patients have opioid use disorder, chronic pain, or both. And so this can be exacerbated both, you know, by behaviors on the provider side and behaviors on the patient side. And on the provider side, if a provider assumes that a patient is drug seeking, is dependent on opioids, or just has really bad pain tolerance and, you know, kind of approaches the situation with a almost, in quotes, suck it up, and the patient picks up on that, that can fuel this patient-provider mistrust. And then on the flip side of that, if the patient was assuming that the provider did not have any empathy for their situation, or the provider was avoiding prescribing opioids because they're just scared of all the repercussions and all the legal implications if something goes wrong, or the patient's just afraid in general that they're not going to be heard or not going to have their condition treated. That can also fuel patient-provider mistrust. And so just wanted to name that these are common implications or psychosocial barriers that present themselves in this patient population. And I have a summary there. And with that, I wanted to introduce our patient case. So we have Miss St. Patrick, who is a 40-year-old transgender male to female patient with pronouns she and they. Past medical history includes opioid use disorder, and of note, she purchases heroin from a dealer. She has chronic low back pain and shoulder pain, and she has PTSD. Currently, she's not on any medications. She states to you, quote, "What's the point? I go to the emergency department for my pain. They don't take me seriously because they think I'm a junkie," end quote. Her chief complaint today is her back pain, which she rates at an 11 out of 10, and she says it's happening all the time. And she describes it as a sharp shooting pain starting at the lower back and radiating towards her hamstrings. So my first question for this patient case is, what are some of the psychosocial barriers to pain and opioid use disorder management for this patient? And once again, feel free to unmute yourself and speak up or use the chat box. Stigma, yeah, thanks, Emily. Yeah, I definitely, there's some stigma here. Anything else? Trust, yeah, some patient-provider mistrust there. Patient thinks that the provider is going to see her as a junkie, which is heartbreaking. So previous provider rejection, yeah, Josh, yeah, probably happened, right? That's probably why she thinks that way. So in the interest of time, I'll share some of what I had down here. So exactly what Emily and Josh said in the chat, you know, there's some stigma associated with folks who have opioid use disorder. Also, this patient is transgender female, and that can also come with some stigma. So that's a potential area. Patient-provider mistrust. And then lastly, this patient has a history of PTSD. So this is a complete assumption, but just something to keep in mind. Maybe visiting the emergency department or the clinic is a trigger for her. We don't know her history there. And we also know that PTSD could be worsened by both opioid use disorder and pain, right? And she has both. Great. So let's pivot a little bit into some principles of treatment. So starting with chronic pain here, we have our non-pharmacologic options available to us, which are physical therapy, a TENS unit, heat and ice therapy, exercise, cognitive behavioral therapy, chiropractors, acupuncture, all non-pharmacologic therapies that we can kind of pursue. And then we have non-opioid pharmacologic therapies, such as acetaminophen and NSAIDs, topical analgesics, SNRIs or TCAs, gabapentinoids, and muscle relaxants. So that's my brief overview there. And pivoting over to opioid use disorder, some of the non-pharmacologic therapies we have available to us, again, CBT or cognitive behavioral therapy with support groups, you know, Alcoholics Anonymous, etc., and then structured rehabilitation programs that we can refer our patients to. And then in terms of medication options, there are three that come to mind, right? And they are methadone, buprenorphine, and naltrexone. So let's do a brief pharmacology review of these three agents. So here on the left side of the slide, I have these little receptors that are periwinkle color. Those are our mu receptors, okay? And we have our red circle, which is a methadone. And you can see here that methadone binds nicely into that mu receptor, or as nicely as PowerPoint would let me do it. And that is a full agonist. So it's going to generate the full effect when it binds the mu receptor. And then if I draw your attention to the graph on the right side, we're going to do a little bit of pivoting just to enforce the learning. You see here that red dotted line is showing you the opioid effect on the y-axis and the dose on the x-axis. So as you increase the dose, you have an increase in opioid effect for that full agonist. Our second one in the orange is buprenorphine. So we see here that that's actually a partial agonist, right? So it's kind of binding and it's generating a limited effect. And so I know all of us here are pain specialists, so we have some idea of the ceiling effect that occurs with buprenorphine. We look at the graph on the right, that orange dotted line, we see that in the beginning, as you're increasing dose, you have an increased opioid effect, and then it does kind of taper off and stay steady after a certain point. And then lastly, we have naltrexone, which is in purple. And that's a complete antagonist. So it blocks the effect on the mu receptors. Then if you look at the purple triangles on the graph on the right, you see here, right, no matter how high on the dose you go, you're just consistently getting zero opioid effect there. And so kind of, a little bit more detail on pharmacology that could be helpful when thinking about these agents, right? We just talked about receptor binding. Thinking about half-life, methadone has a short half-life, which is about 8 to 12 hours, and the prolonged half-life, that's 5 to 7 days. Buprenorphine is formulation dependent. I promise we're going to go into that after we've kind of done our overview, since there are so many different formulations available to us. And then we have naltrexone, which the oral formulation has a half-life of about 4 hours, and the intramuscular has half-life of about 5 to 10 days. Thinking about typical dosing, induction for methadone starts between 10 to 30 milligrams and then can be up titrated. Usually dosed once a day for opioid use disorder, but splitting that into BID or TID dosing is actually more beneficial for pain. And then naltrexone is dosed once daily between 25 to 50 milligrams for opioid use disorder. And then the intramuscular dose is administered every 4 weeks. So thinking about that from an adherence perspective could be helpful. Just for we're pharmacists, so we really like to know our renal dose adjustments and hepatic dose adjustments. So for methadone, there's no clear cutoff or contraindication from a renal dose adjustment point of view, but just knowing that the metabolism is a little bit slower for folks with clearance creatinine less than 10. So just kind of watching that dose and titrating slowly. And then for hepatic dose adjustments, thinking about naltrexone, how it's not recommended in acute hepatitis or hepatic failure. And then lastly, thinking about some of the formulations we have available to us. So buprenorphine, there are a ton of them. Methadone, we have tablets and oral solution. The IV is very rarely used. And then the naltrexone, we kind of touched on this for dosing, but we have the tablet and the intramuscular injection. So kind of comparing them from less of a pharmacologic standpoint and more of side effects and decision-making, kind of critically thinking about this. So if we think about pain relief, methadone is a full opioid agonist, so that's going to give us some pain relief, yes. Buprenorphine is a partial agonist, so that's also going to give us some pain relief. And naltrexone is a complete antagonist. We're not going to get pain relief from that. From a respiratory depression standpoint, methadone, since it's the full agonist, has a higher risk of causing respiratory depression, right? Buprenorphine, because it's only a partial agonist, it has that ceiling effect. There's a little bit of a lower risk of respiratory depression with that one. It's a little bit safer. And then naltrexone antagonist, so no risk of respiratory depression. Thinking about how to administer these medications for folks who have opioid use disorder, right? So methadone is typically given, if it's once daily dose, it's like the patient comes into the OTP clinic or the opioid treatment program clinic and has to get it daily. So thinking about transportation and how that works logistically, especially for folks who are younger and still working and have other lives or going to school. Thinking about buprenorphine and naltrexone, they can be administered in an OTP clinic, can also be prescribed by PCPs and taken as an outpatient. Thinking about sedative side effects, right? So methadone is sedating, buprenorphine is sedating, and naltrexone is a very, very rare side effect of naltrexone. Thinking about withdrawal if you initiate it. So again, methadone full agonist, we're not going to really see withdrawal because we're going to just replace it, right? And get that full effect. Buprenorphine may cause withdrawal when kind of switching from a full agonist opioid over to buprenorphine, and can be mitigated by buprenorphine low dose initiation, more colloquially known as microdosing. And we're going to talk about that too. And then naltrexone, if you can imagine, is a complete antagonist. If someone's using opioids, full agonist opioids, and then suddenly gets hit with the naltrexone, which has the higher binding affinity and is going to knock that full agonist opioid off and cause some severe withdrawal. And usually if someone is actively using opioids and is opting to try and or use naltrexone for as their medication option, they'll do that inpatient and do a little trial. And then lastly, kind of thinking about is pharmacologically, if a patient had acute pain or had a procedures, or is a palliative care patient who needs some breakthrough agent, maybe you can use short-acting opioid agonists for breakthrough pains in a patient who is on methadone, in a patient who is on buprenorphine, but you cannot do that for a patient who's on naltrexone. So as promised, going over our buprenorphine formulations. So I have first 3 listed as the buprenorphine formulations that are FDA approved for pain alone. And so I have the Butrans patch, Belbuca, which is the buccal film, and Buprenex, which is the IM or IV formulation. I have the max dose listed there, and I have the half-life on the slide for your reference. I'm happy to share these slides with anyone who'd want to see them. But what I wanted to point out here is that top 3 that are approved for pain, maybe not the IM IV version because that dosing is a little bit different. If we're looking at the Butrans patch and Belbuca, we're looking at microgram dosing, right? So much lower dose. And then if we go towards the bottom of the table and look at the 2 formulations that are FDA approved for opioid use disorder and used off-label for pain, we think about Suboxone, which is the combo of buprenorphine and naloxone, and then you think of Subutex. And those 2, if you look at the max dosing, we're looking at milligrams now. So much higher dosing for opioid use disorder as compared to pain. And that's to achieve kind of that blocking effect. So as promised, we're going to talk a little bit about buprenorphine microdosing or low dose initiation. And for those of you who went to the Palliative Care and Hospice Medicine conference last month, this might look familiar if you attended the buprenorphine talk. I adapted the slide from them. I thought this was a really good kind of visual to explain why buprenorphine has the potential to precipitate withdrawal in someone who is on full agonist opioids previously. And so if we look at this first diagram with the 2 cars in the A line, right, and that's labeled precipitated withdrawal, essentially you can think of someone who's on full agonist opioids having their mu all covered up and having that full effect as a car that's cruising on the highway about 120 miles per hour, okay? And then if you slap them with some buprenorphine immediately, right, you're essentially, buprenorphine has a much higher binding affinity for the mu receptor than the other opioid that's bound. So you have that ceiling effect. And within minutes, you're bringing this car to a screeching slowdown and like almost immediately bringing them down to 60 miles per hour, right? You still have some opioid effect, but it's really going to slow them down and be like cruise at 60 miles per hour, not 120. Okay, and that can be uncomfortable. Then if we look at the B or the B row here, this is supposed to represent classic induction, right? Where, you know, someone's on full agonist opioids, going at 120 miles per hour on the freeway, and over hours to days, depending on what dose of full agonist opioids they're on, kind of slowly tapering them down. So there's no abrupt, you know, slow down, but you kind of like slowing them down slowly, bringing them down to 30 miles per hour, which, let's get real here, 30 miles on the freeway doesn't feel that great, but, you know, we're managing, we're still moving. And then introduce the Suboxone or whatever buprenorphine product, and then kind of bring them back up to the comfortable 60 miles per hour, right? And so that's kind of classic induction. And then if we look at row C here, this is supposed to represent low dose initiation. And so again, we're starting on our full agonist opioids, 120 miles per hour, and kind of over days, maybe like day 5 days or so, we just kind of slowing down slowly. So we're slowly introducing micro doses of buprenorphine and kind of bringing them down gradually from 120 down to 60 miles per hour eventually, without any abrupt stopping or without going so slow that it's just uncomfortable. And so thinking about how can we introduce these low doses of buprenorphine slowly, right? And there are various ways to do it. So you can do it with the IV version, you can do it with the transdermal patch, you can do it with the Suboxone sublingual tablet or sublingual film, and we can do it with the buccal film. And so there are pros and cons to each version. The IV version, it's a rapid onset and you can have a rapid transition, typically done inpatient because you need IV access. And that kind of goes into the cons, is that IV access is needed, and also because it's happening so fast, that may actually precipitate some withdrawal, which is kind of ironic because we're doing this protocol to avoid withdrawal. Thinking about that. The transdermal patch, the pros are it's really easy to use. Some of the cons are it's indicated for pain. So if we're thinking about insurance reimbursement, there might be some complications there because we're using it for opioid use disorder, and there can be kind of a disconnect there. Takes about 72 hours to reach steady state, so it might be a slower process. And then the Butrans patch is actually quite expensive. So especially if your insurance is not reimbursing for an off-label use, that could be quite pricey. Then we have the Suboxone sublingual tablet or film, which actually most clinics do opt for this version or this type of low dose initiation, just because they can prescribe the Suboxone and kind of keep the patient on the same dose and have them split the films or the tablets. So it's accessible. It's really accessible. It's quite easy to do, but there is a concern about stability when quartering the tablets. And if we think about the lowest dose available, the 2 milligrams of buprenorphine, kind of quartering that to get to a 500 microgram dose can be challenging. And then lastly, we have our buccal film, which has a quick onset of action. It's actually less expensive than the Butrans patch. But the cons are, again, it's indicated for pain. So it could be an issue if we're trying to get insurance reimbursement there. And so thinking about how do we optimize, we've talked in real depth about like 3 options we have available to us, pharmacologic options we have available to us for opioid use disorder. So now kind of reframing our minds to think about this in the context of someone who has both opioid use disorder and chronic pain. Well, what can we do with these 3 options? And so we've already kind of talked about how naltrexone is not really going to give much pain relief, right? For antagonizing the mu receptor, we're really not going to get that. We also talked about how splitting up the methadone dose into BID or TID dosing can provide some better analgesic effect. This is also true of buprenorphine products, right? So one thing to consider is splitting up the dose. Something to keep in mind when splitting up the dose is actually OTP clinics generally only allow once daily dosing. So thinking about methadone in this context, depending on the OTP clinic, they make exceptions for different things. Over here in San Francisco, VA, typically the exceptions are made for pregnancy because they just metabolize methadone faster. And then for folks who maybe have really bad kind of respiratory depression or history of sedation from the high dose of methadone, they allow them to split it up. Typically not allowed to split up their methadone dose for concomitant chronic pain. So something to keep in mind there. And then the pro of maybe using buprenorphine in this patient population is that it can be prescribed by PCPs and then picked up at a community pharmacy, and then the patient can kind of determine how they want to split up that dose. And so bringing back this diagram of kind of principles of treatment and kind of putting together what we know about chronic pain treatment or chronic pain management and opioid use disorder management, the non-pharmacologic therapies, as much as the patient is able to, we can employ aspects of both, right? The one overlap was CBT, so we can do that for pain and substance use disorder. We have our pain ones, physical therapy, TENS unit, heat ice therapy, exercise, chiropractor, acupuncture. And then we can also encourage the patient to be engaged in a structured rehabilitation program if that seems that it would be helpful for the patient. Then we have our non-opioid pharmacologic therapies to manage pain and kind of optimizing that. So we have our acetaminophen and NSAIDs, topical analgesics, SNRIs or TCAs, gabapentinoids, and muscle relaxants. And then lastly, we have our opioid pharmacologic therapies that are available for this patient population, which also double as blocking agents, right? So we have methadone or buprenorphine, and we can consider splitting up that dose. Again, the methadone dose might be a little bit more challenging to do depending on the OTP clinic's rules and regulations. And so I wanted to spend some time, we talked a little bit about the psychosocial barriers that exist in this patient population. So I wanted to take a little bit of time to kind of go over some tips and tricks that can kind of help us overcome those. And so we talked a lot about stigma. So some ways to kind of begin to undo the years of stigma that these patients have, quite frankly, faced more than they've had to, is using patient first language, right? So saying patient X has opioid use disorder instead of patient X is an opioid addict, right? And then also just being very objective in using medical language when we're describing test results, right? So saying patient X, your urine drug screen was positive for cocaine instead of your urine drug screen came back dirty, right? So kind of keeping it more objective and treating it the same way that you would say, you know, patient X, your A1C came up above goal, treating it the same way. Assume best intent always, you know, so let's say you have a patient who's run out of their opioid medication early, instead of jumping to a conclusion of, oh my God, they're misusing it, just start with just make an observation. Looks like you've run out of your opioid medication early. Tell me about how often you're using it, and allow the patient to tell you what's going on. Use reflective statements to show that you're hearing them, right? You want to make sure the patient feels heard, feels like you truly care, right? So it sounds like you took your opioid medication more than prescribed because you were scared your back pain would flare during your grandson's graduation. That's very legitimate, right? And then be sympathetic when addressing opioid misuse, right? So it needs to be addressed, but it can be done very respectfully in a way that's not stigmatizing. And one example of the way you could do that is, it must have been very frustrating and upset to have to worry about a pain flare interrupting a happy moment in your life. And you using opioids more than prescribed makes me worried about your safety, right? So acknowledging both aspects of that, super important. Also wanted to take a minute to address some risk mitigation strategies that we can employ in all patients who are either using substances or we're prescribing opioids for. And for this patient population specifically, avoiding full agonist opioid therapy unless the patient is having acute or cancer pain. This is obviously not counting methadone, even though that's a full agonist, you know, that's an approved medication for opioid use disorder. Using the lowest effective dose of methadone or buprenorphine, which gives the patient good pain relief and good blocking effects, so they're not having any cravings. Minimizing the use of other CNS depressants. So examples include benzodiazepines, muscle relaxants, and gabapentinoids. Routine monitoring of urine drug screens and state prescription drug monitoring. So here in California, we use Cures. Offering naloxone prescriptions and education. I don't know for other folks, I know for our VA folks, this is quite accessible because it is free of charge. I'm remembering from my API days when I worked in a community pharmacy that it can be quite pricey for other folks. So kind of weighing the risks and benefits there. And then if available at your institution, offering harm reduction resources and supplies. So examples include fentanyl testing kit, syringes, sharps disposal container, condoms and STD screening, resources for rehabilitation sites, and resources for safe injection sites. For the safe injection sites, they're easily, you can Google them easily, and they're actually oftentimes do offer these harm reduction supplies. So if it's not available at your institution, you can Google them and direct your patient there, as well as they do sometimes also offer naloxone free of charge. So that can be an alternate for your patient. So coming back to Miss St. Patrick, this is the same history that we got before. So I'm just kind of putting it up on the slide for you to kind of refresh your memory. The one additional detail we got now is that we know she uses 1 baggie of heroin a day, and a baggie of heroin is about 15 milligrams. And so today she would like to receive treatment for her pain. What non-pharmacologic and pharmacologic interventions would you consider for this patient? And so let's start with non-pharmacologic, and feel free again to unmute yourself and speak up, or to put your answer in the chat. CPT, yep, physical therapy. Thanks, Emily. April also said physical therapy and stretching, right? Self-directed exercises. I love that. Acupuncture, yeah, Jasmine. Elizabeth says heat and ice therapy, yep. All great strategies. So I essentially went ahead and listed all the options we have available to us. Obviously, this would be a risk-benefit discussion with our patient and kind of some joint decision making as to what our patient thinks would be most helpful for her. But yeah, these are all the things we have to offer her. It also included some of the risk mitigation strategies we just talked about. Since she is actively using heroin, I didn't have a detail on how she's using it, but if she is injecting it, right, offering those risk mitigation strategies or offering those safe supplies would be helpful for her. What about some pharmacologic options? And hint, hint, she's having some sharp shooting pain that's radiating from her back to her hamstrings. And she's not on any medications currently. Any suggestions? You can do methadone, yeah. Definitely do methadone to kind of treat both her pain and her opioid use disorder. If she's open to it, yep. I see duloxetine, yep. Great option for some neuropathic pain there. Ibuprofen, acetaminophen, yep. All viable options. And so I will reveal, and then I see Flexeril short course, maybe, yeah, Josh, especially if she's having some muscle spasm, for a short course could be an option. So I have here acetaminophen and NSAIDs are reasonable to consider. I obviously have provided you with very limited information. We would look at her labs and other comorbidities, although I have a problem list there and she doesn't have any cardiac comorbidities or renal comorbidities to think about right now. Gabapentinoids can be helpful for neuropathic pain. I know no one recommended it. I think my one concern with starting a gabapentinoid, it has an increased risk for respiratory depression, and she's actively using heroin, so I might steer clear of that one since we do have a better option of duloxetine. The Flexeril, it really depends on whether she's having muscle spasm or not. I assumed in this slide she's not having muscle spasm, so I said I'm not going to do it. It's also some muscle relaxants have an increased risk for respiratory depression, so maybe avoiding that. Really depends on what information she gives us. And then topical agents are generally benign and well tolerated. So I think about lidocaine patch because it's once daily dosing and can be a little bit easier than applying like menthol and salicylate or lidocaine ointment 4 times a day. So I think about methadone's absolutely right. I did not include opioids on this slide, but we will talk about methadone, April, I promise. So we'll get back to that. And so let's say you've had a great risk-benefit discussion, offered all these options to Miss St. Patrick, and she says, okay, I want to start duloxetine and I want to start a lidocaine patch. And so she's like, I'm going to do that. And she comes back to you 3 weeks later, her back pain went down from an 11 out of 10 to a 6 out of 10. She says her mood's much better. And she's still using 1 baggie of heroin. Before it was once a day, now it's 2 to 3 times a week. So we're seeing that even just treating her pain was helpful. Yeah. So now you've built some rapport with Miss Patrick, and she tells you she wants to start a medication for her opioid use disorder. What medications do we have available to us, and what would we recommend initiating for this patient? And I've kind of set this out because I know we've talked in depth that there are really 3 options, right? We have methadone, buprenorphine, and naltrexone. And I thought we could work together to maybe list some pros and cons of each of these medications. So starting with methadone, I promised you, April, we got back to it. What are some pros of using methadone? Treats pain and opioid use disorder, yep. Anything else? I'll reveal my answer. So that was definitely one of them. The other thought I thought was, it's okay for her to use methadone while taking other opioids. So if she's not ready to completely stop using heroin, there is an increased risk of respiratory depression, but we're not going to induce withdrawal. What about some cons of methadone? Access and burden of administration. Yeah. So she's going to have to go to that OTP clinic. We don't even know if her OTP clinic will allow multiple times a day dosing, which is what we know is best for pain. The other one I listed was increased risk of respiratory depression, since she's still actively using heroin. Yeah. All in all, is this a viable option? If you present these pros and cons to Miss Patrick and she wants to do methadone, is that okay? Yes, yeah, absolutely. Viable option. All right, thanks, April. We did a great methadone discussion right here. What about buprenorphine? What are some pros of buprenorphine? Okay, I see Josh says, doesn't need to go to clinic daily, exactly, right? PCP can prescribe that. Sandy says also concomitant pain relief. Yeah. So I have concomitant pain relief listed here, ceiling effect for respiratory depression, multiple dosage forms. Love it, Jasmine, Emily. I see you. So I actually didn't even list the clinic pro, but that's definitely a pro. Yeah, what are some cons? Okay, I will list the one con I thought of. Oh, Josh says none, and I, honestly, yes, it's close to none. If we don't do any microdosing, there's potential for withdrawal. Yeah, that's the only one. Yeah, withdrawal with heroin. Thanks, Sarah. So all in all, if we've presented the pros and cons of buprenorphine products to our patient, and she's like, yeah, I want to take it. Is this a viable option? Can we allow it? Yes, Josh. Yes, Jasmine. We can allow it. Then lastly, we have our naltrexone. What are our pros of naltrexone, if any? No risk for respiratory depression. Yep. Also doesn't have to go to clinic. It's accessible. Yep. So those are all pros of it. I didn't list those. My one pro that I could come up with, so I clearly have a bias here, was it's once daily dosed. What are some cons of using naltrexone in this patient? Withdrawal. Yep. Actively using heroin. Not really any pain relief. Exactly. Those are the two I have listed here. Bad evidence for efficacy. Yeah, Josh, that's also a big one. It's pretty low retention rate. And so keeping in mind that she's also still actively using heroin, if we did present these pros and cons to her and she did choose to start naltrexone, could we actually safely prescribe that for her? Not today. Yeah, exactly, Emily. And that's what I said. It's not today. Not today. All right, so kind of the take-home points. If you don't walk away with anything else, these are the 5 take-home points I want you to walk away with today. Is the intersection of chronic pain and opioid use disorder is complex and challenging to address. Chronic pain cannot be adequately treated without treating the concomitant opioid use disorder. You've got to treat them both. Interdisciplinary and interprofessional care is key to patient success, right? So we want our experts in substance use disorder involved, we want our experts in pain involved, and we want, in addition to us pharmacists, we want our physicians, our nurse practitioners, our physical therapists, our psychologists, right? We need all hands on deck. We want to optimize the non-pharmacologic and non-opioid medication regimen for pain. I just kind of went ahead of myself. I already talked about how amazing our colleagues in other clinics are. So we'll just reiterate that. So I know at least here I rely heavily on them. And with that, I just want to thank my RPD, Dr. Sarah Labroto, and then my preceptor for substance use disorder, Dr. Marcus Ellis, both helped me put this presentation together. And with that, I'd like to open up the floor for discussion, reflections, questions.
I do have a question. That was first an awesome presentation. That was really good, encompassing everything and giving a good overview of everything. The question I had, and you just like briefly touched on it, and this is kind of, I think, outside the scope of your presentation. So if you don't know the answer, it's totally fine. But I've been hearing more that like gabapentinoids have been high medications of abuse as well. I guess as you were going through, do you have any thoughts about the correlation of gabapentinoid abuse with OUD, or whether we should avoid prescribing gabapentinoids in patients with OUD because they're becoming more abusable, or I guess abuse?
Oh, thanks for the question, Josh. Yeah, I did not actually kind of do, my research didn't encompass looking at the incidence of kind of the overlap between opioid use disorder and gabapentinoid. So I would have to look into that. But just kind of thinking about it, there was a presentation a couple of years ago from actually the first PGY2 resident in this position, did an extensive presentation on gabapentinoid abuse, and I agree it's kind of increasing. I would think about it in the same way that I think about like prescribing benzos for a patient who has opioid use disorder, right? There's a risk for respiratory depression in both of them. There's a risk for abuse potential in both of them. And so there's kind of a time and a place. And so for when I think about benzos in that way, I say like acute needs, if they're going to have a procedure or, you know, kind of use it sparingly there. And with gabapentin, kind of the indications are a little bit more chronic. So if they've been stable on it in the past and haven't abused it, I say, why not? If they have not been on it in the past, but they have neuropathic pain and we've kind of exhausted other options or have contraindications to maybe the SNRIs or TCAs, then maybe I'd kind of have a risk benefit discussion with the patient and see how they kind of decide whether they want to trial it or not. And then it'll just be close monitoring and for me. So I guess my TLDR version is it depends, and I would really kind of exhaust my other options before I reach for a gabapentinoid. The only situation where I might prefer using a gabapentinoid or gabapentin specifically would be if the patient has concomitant alcohol use disorder, since that can help with cravings.
Awesome. That makes a lot of sense. Thank you.
Mm-hmm.
Any other questions? Comments? All righty. Well, I guess that wraps it up. Nisha, thank you. Lovely job. We really appreciate it. And thank you all for tuning in, and we'll see you next week.
Thank you.
Bye-bye. Bye.